I would now like to introduce our physician speakers, and I'm going to ask our panel to turn their cameras on at this time. Dr. Kathleen Harnden is board certified in medical oncology and internal medicine. She has a special interest in the management of breast cancer, particularly in pre-menopausal women. Dr. Harnden joined Inova Cancer Institute after the completion of her hematology oncology fellowship at Duke University Medical Center in Durham, North Carolina. She is also an MBA graduate from the University of Virginia Darden School of Business. Dr. Harnden has numerous publications in national journals and has presented at national meetings. Her research has focused on early phase clinical trials in breast cancer genomics, and individualized treatment for patients based on advanced testing results. She is and has been a principal investigator on several phase 1 clinical trials in metastatic breast cancer and is interested in developing novel therapies for breast cancer. Dr. Stella Hetelekidis is a specialty care physician board certified in radiation oncology. She joined Inova in 1999 and has been practicing since 1993. She specializes in breast and gynecologic malignancies and treats her patients. She helps her patients understand their diagnoses and options and works together with the patient and her fellow physicians to develop a treatment plan. She's a graduate of MIT and of the University of Rochester School of Medicine and completed a residency in radiation oncology at Harvard Medical School. Prior to joining Inova, Dr. Hetelekidis practiced at the Brigham and Women's Hospital and the Dana-Farber Cancer Institute in Boston. Dr. Lauren Turza is a specialty care physician board certified in surgery at Inova Health System. She joined Inova in 2022 and has been practicing since 2009. Prior to joining Inova, Dr. Turza served in the U.S. Army for 17 years. She received her undergraduate degree from Columbia University and attended Uniformed Services University of the Health Sciences for her medical school in Bethesda, Maryland. She completed her internship and residency in general surgery at the National Capital Consortium of Walter Reed National Military Medical Center and a fellowship in breast surgical oncology at Anne Arundel Medical Center in Annapolis. She was the chief of breast surgery and director of the breast center at Walter Reed National Military Medical Center and at Tripler Army Medical Center. She also served as the cancer liaison physician for the Commission on Cancer at Walter Reed. She is assistant professor of surgery at Uniformed Services University of the Health Sciences and has published her research in peer-reviewed journals. So I would like to welcome our distinguished panel. And at this point, we're going to start answering questions. And we've had several questions that actually came into us this past week. I'm going to start reading those and ask our panel to respond. Can you explain the different surgical options available for breast cancer and how a patient might decide which is best for them? And I think that would be Dr. Turza.
Yes. That's a great question. It's a multi-hour answer, so I'll try to condense it as succinctly as possible. So in general, we highly customize surgical management, so it really depends on the location of your tumor, the size of your tumor, as to what's possible. There are general classes of management for surgery. So there's a class of care called breast conservation. And then there's mastectomies. So in breast conservation, we're trying to remove the tumor from the breast, leave the surrounding breast tissue, and then we treat the breast with generally radiation, which I'm sure Dr. Hetelekidis will get into more details on that. Not every patient requires radiation in those settings, but we highly customize that approach. The goal in breast conservation is to leave your breast tissue looking very normal, or as normal as possible without significant defects. We try often to hide scars and to minimize the cosmetic impact. Sometimes for larger tumors, we're able to remove them in this setting with the use of doing concurrent oncoplastic reductions, so doing a breast reduction in conjunction with your breast cancer surgery, and that many times involves a plastic surgeon. For mastectomies, it's a little bit larger of an operation, but a very good option for many patients with breast cancer. There are a lot of different ways we can do mastectomy these days. Some women choose to have reconstruction, others do not. For women who do not undergo reconstruction, we do an aesthetically flat closure to remove the excess tissue and skin. So for women who want to wear external prosthetics, that's a possibility. For women who choose reconstruction, there are a variety of different incisions and types of reconstructions that we can do with the mastectomy to optimize the outcome and appearance of the breast. In many situations, we can leave nipples safely if your cancer is far enough away from it and it's cosmetically optimal to do that. So this is a highly detailed conversation with a breast surgeon and plastic surgeon as to what's an option in terms of the types of reconstructions. The both kind of classes of surgery are possibilities for different patients. Not everyone is a candidate for both of them. And so we try to customize it for the patient. The good news is in a modern era, there's very similar outcomes in terms of local recurrence and overall survival, depending on whichever class of surgical management you decide. So lots of good options now where we try to minimize pain and optimize cosmetics while removing your breast cancer.
Okay, thank you. This next question is for our radiation oncologist. What role does radiation therapy play in breast cancer treatment, and what should patients expect during the process?
Okay, thank you. Good follow-up question there. Many breast cancer patients will receive radiation therapy, which is basically high energy X-ray treatment directed to the breast and the lymph nodes if they're either involved or there's a high chance they might be involved in the future. In the breast conservation setting, many decades ago, there were multiple studies around the world showing that for patients with early stage breast cancer, lumpectomy and radiation therapy offered the same rate of control and survival as mastectomy. Most patients who undergo lumpectomy for breast cancer will receive some type of radiation therapy. And what it does is it reduces the risk of local recurrence. Compared to patients who have lumpectomy alone, the risk of recurrence is much lower when radiation therapy is added. There are also patients who undergo mastectomy who have either large tumors or locally advanced tumors that involve the lymph nodes that have high risk of recurrence locally, either on the chest wall or in the lymph node area. And those patients also benefit from radiation therapy after their surgery. So in both situations, the radiation therapy is helping to reduce the risk of recurrence and improve the chance of survival.
Okay, thank you. Next question for our medical oncologist. Can you discuss the various medical treatments available for breast cancer? Chemotherapy, hormone therapy, other targeted therapies?
Yes, so that is a very good and very broad question. So in breast oncology, we focus on individualizing treatment, just like our other two physicians have explained in a similar mindset as to what they discussed in terms of what does the cancer appear to be doing? How large is it? Is it in the lymph nodes? Is it just in the breast? And the individualization of treatment for breast medical oncology really focuses on minimizing the risk of spread to the body, which is sort of one world that we take care of for our breast cancer patients, is how do we maximize cure rate and minimize spread? And then there's this other really important part where we have our patients with spread breast cancer, and we have particular individualized treatments in that setting. In both scenarios, our focus is to maximize benefit and minimize toxicity, and we utilize a huge number of targeted resources and genomic testing to help us determine what the right treatment plan is for a patient. In the curative breast cancer setting, there's three main types of breast cancer that we individualize the treatment plan for. a hormonally fueled breast cancer that's estrogen positive and HER2 negative, a triple negative breast cancer, which means that it's not estrogen and progesterone fueled, and it's also HER2 negative. Those are the 3 receptors we can try to target. And then lastly, HER2 positive breast cancer. And we have a huge number of tools between anti-hormone therapy. We have some anti-hormone therapies that actually don't overall change the hormone levels in the body, but target certain receptors on the cancer. We also have HER2 targeted therapy that targets the HER2 receptor on the breast cancer. And then triple negative breast cancer, we utilize both chemotherapies, which are medications that kill fast dividing cells. But in triple negative breast cancer, we also utilize immunotherapy. And then in the metastatic setting or spread breast cancer setting, we really utilize even more tools, more targeted therapies, quite complicated ways of targeting the cancer without targeting our healthy normal cells. And then we utilize a lot of advanced testing, looking at the DNA level of the cancers and trying to sort out how we can best optimize any escape pathways that the cancer might try to use. And then, of course, in breast medical oncology, one of our lead focuses in the clinic is clinical trials. And so we utilize those both in the early stage setting and the metastatic setting. And we're trying to always make treatment better, more effective, and less risky with less side effects. And so that is both a general and broad answer to what is a very important but very broad and individualized question.
Okay, thank you. I want to remind everyone that you can put your questions into the Q&A at any time. But we still have a lot of questions that came to us ahead of time, so we're going to continue with those as well. Can you comment on the multidisciplinary approach to treating cancer? How important is it to have a multidisciplinary approach in developing a comprehensive care plan for breast cancer patients? I'm not sure which of you would like to take that one.
I can take this question. So this is highly important. Cancer care is incredibly complex. And like you just heard, we all play a role for patients. And I think understanding how we all fit together is one of the keys. In certain situations, we try to see patients maybe on the same day who are coming in, or at least see patients in close time periods to each other, so that patients can hear each of our own perspectives. As the breast surgeon, I'm usually one of the first people who will see the patient. And so setting the expectation of how we all fit together is really important. From a local control treatment, understanding the impact of surgery and radiation and how they relate can be very important at making decisions. And so kind of understanding all the key components is important.
Okay. What resources are available for patients and their families to help them navigate the emotional and psychological aspects of breast cancer treatment?
I'll be happy to answer this one. So that is a very important part of treatment. Going through cancer diagnosis and cancer treatment is stressful and really very time consuming as well. And emotionally, it can really affect patients and their families. At Inova, we are incredibly fortunate to have a program that's called Life with Cancer. This has been around a long time, over 25 years, maybe 30 years. And it is a program that started small and now is quite extensive, providing services that are free to cancer patients and their families. And this includes counseling. This can be one-on-one counseling. It could be support groups that are available. There are talks for learning about different kinds of cancers. There are exercise classes, massage therapy, acupuncture, and other services are also offered. Most of them actually free of charge because of the tremendous fundraising that is done in our community to fund this program. Part of the funding comes from Inova, and the rest of it comes from the community. It really is I don't think I've ever seen anything quite like it. It's really a fantastic program. And we're very fortunate to have it. Within my own department, radiation oncology, at Inova, we have 5 radiation oncology departments at the various Inova hospitals and 1 in Woodbridge. We have a social worker who is in the department and sees every new patient as they come through. Some patients need that person's services. Other people just say hi and bye, but they are available should the person need them. And even after they're done with their actual radiation treatment, even today, my social worker in our department had an appointment with someone who had completed his treatment a couple of months ago. So this is a wonderful program that's available.
Okay, thank you. Let's talk about early detection. How does early detection influence treatment options and the overall outcome for breast cancer patients?
I'll answer this. So it's highly important. Getting your mammograms and getting them annually is very, very important. Early detection is the key to improved overall survival and great outcomes and minimal impact by treatments. Generally, we recommend annual screening mammograms. Let me also take a minute to distinguish between what a screening mammogram is and what a diagnostic or comprehensive mammogram is, because this is actually having huge impact on our community right now. So a screening mammogram is for a patient who does not have any active symptoms. So this is, you're getting your annual follow-up. You might have had your exam by your primary care doctor or your gynecologist, and this is just a routine. They didn't find anything on exam of concern. It's generally offered in either a 2-dimensional or 3-dimensional tomosynthesis option. Either one is fine for women with dense breast. Generally, the 3-dimensional option is a little bit helpful. It decreases the rate of callback, meaning if they see something that we're going to ask you to come back. So I highly recommend just sticking with your screening mammograms. A diagnostic mammogram, which was also formerly called a comprehensive mammogram, is actually the same mammogram that a screening mammogram is in terms of the traditional views. The difference with the diagnostic is they allow more time in the appointment so that if additional views have to be done to work up a specific area of the breast, whether that's on magnification views or we need to add on an ultrasound, that time is available for the patient. So it's more like an hour appointment versus a 10-minute appointment that a screening mammogram is. I'm bringing this up because a lot of patients are getting comprehensive or diagnostic mammograms when they don't have symptoms. And what's happening is because people feel more comfortable that it's more kind of advanced technology to get that. And what's happening is if things are getting flagged on your mammogram, it's taking a long time to actually get that appointment for a comprehensive or diagnostic workup that's then required. So I highly encourage just sticking with your routine screening mammogram. So it's very important to get that. We can customize what type of screening is recommended, but in general, just the screening mammogram is fine. If you're concerned about your breast health or you have a family history or you're concerned about your personal risk factors, you can always be seen in the breast center and we can do a comprehensive evaluation to see what your true risk of breast cancer is based on multiple different calculators that are available out there. And then we can customize whether a mammogram is enough. We also recommend getting a breast exam by a clinical provider once a year. That's very important. Screening mammograms start at age 40, but if there's a concern that you're having with your breast sooner than that, I highly encourage that you get evaluated. You're always welcome to be seen in the breast center. Some patients, depending on insurance, need referrals to see us, others don't. But if you're concerned, we would rather see you and evaluate you rather than you sit at home and worry.
And what about the upper age for mammograms? Is there a point in time that you don't need them anymore?
That's a really great question. So this is debated depending on what society or group you look at. I would say the American Academy of Radiology and the National Breast Societies generally recommend that you continue screening mammograms until your life expectancy is only maybe 5 years or so. So it's kind of customized to what your health is, because age can't be a discriminator for all patients. So it really depends. I think if you are, I think for elderly patient, there's a lot of concern sometimes that maybe I shouldn't get that mammogram because I don't want to have any breast cancer treatment. I don't want it to affect the quality of my life. But actually, breast cancer treatment, if we pick it up nice and early, sometimes even when you're at a more advanced age, sometimes a minor surgery is all that you need. We try to highly customize it so we're not creating harm. So I continue to get screening mammograms in my patients, even past, an age of 80. It really depends on your personal health.
Okay,
And
thank you.
I'll add to what Dr. Turza said. That was all excellent and really helpful. Also, that from a treatment perspective, the earlier you find the breast cancer, you can have vastly less treatment. Your surgical options can be more broad when it's found, smaller and more limited. You can sometimes avoid the need for radiation, or your radiation can be more targeted. And then from a medicine to the body perspective, you can require, half as much treatment or even less. And sometimes you don't even have to necessarily do treatment if you catch it in the precancer stage. And so entirely agree with, you want to make sure you get your mammograms at a minimum age of 40 or by 40 for sure, and starting at that point forward, all the way until, I agree with what Dr. Turza said about life expectancy, because some women, if they have a small breast cancer that we biopsy and we realize that we can put them on a medication or do a very minor surgery, these are things, or potentially even targeted radiation, these are things that are quick and easy. And so at either end of the spectrum, mammograms save lives, and they also save women from extra unneeded treatment if it's found earlier.
Thank you.
I'd like to add something too. I totally agree with everything here. This is actually a very important point to continue on what Dr. Harnden said. For example, patients where we find very small breast cancers, many times they don't need radiation therapy. And if they do, we can do a very targeted radiation treatment just to the area of the surgery. It's 5 easy treatments, has almost no side effects, and women do very, very well, as opposed to 3 or 4 weeks of treatment, which is kind of standard if you're treating the entire breast. The other thing I'd like to say is that I frequently run into people who say things like, gosh, I didn't think I needed a mammogram because there's no history of breast cancer in my family. The vast majority of patients we see with breast cancer have no history of breast cancer in their family. And the bottom line is, if you have breasts, you're at risk for breast cancer. So everybody should get their mammogram.
Okay, thank you. Here's an interesting question. If I've had a mastectomy, do I still need a mammograms?
No, you do not need a mammogram. There is no national guideline suggesting that you need screening. We've removed your breast tissue if you've had a mastectomy. Now, it's not 100% removal of breast tissue, but it's over 95% removal. And so what I mean by that is that our breasts are suspended to our skin through tiny little tendrils of tissue. All the tissue that's visible is removed, but there is still microscopic breast tissue that attaches to the skin. So we can't remove it 100%. The way we screen for a recurrence after a mastectomy is using clinical exams. There are certain situations where we will do breast imaging. So usually it's an ultrasound or potentially an MRI. If you've had a mastectomy, if we're concerned about an area, we may work it up if we've identified something on exam, but there's no indication to get a mammogram. Now, there are certain situations where we might err on the side of getting it, and that's kind of a complex answer there, but it's not part of routine screening. The clinical exam is the most important thing to screen after a mastectomy.
Okay, thank you.
Probably to clarify, if a mastectomy has been done on one side, of course, you continue your mammograms on the other side.
Thank you. Yes, absolutely.
Okay, this person says, I have a family history of breast cancer. Will having a mastectomy prevent me from getting breast cancer? Should I do that?
Okay, I'll take that one too. So having a family history of breast cancer does not necessarily mean you will get a breast cancer. It goes into the risk analysis that we do. So if you are concerned about that, I highly recommend coming in for a personalized assessment, because things like our breast tissue density, our exposure to estrogen in our lifetimes, biopsies that we've had, family history, all these things play a role in what our individual risk is. Doing prophylactic breast surgery to like a mastectomy to remove the breast tissue can be performed. It's usually reserved for women who may have higher risk genetic mutations, or individual risk is much higher based on a variety of different risk factors that I just mentioned. So I would not say that that every patient with a family history should have a mastectomy. That's not needed. It's over treatment. But we can highly customize that conversation and talk about if that would be of benefit if you come in for an evaluation in clinic.
Okay, Dr. Turza, I think this next one is for you too. If I choose to have a surgery, is mastectomy my only option?
So that depends on the presentation of your cancer. So women, most women are candidates for a mastectomy, and we have to evaluate whether women are candidates for lumpectomy. Although, like you heard Dr. Hetelekidis, most women actually do undergo lumpectomies for their treatment. So it kind of depends. If you have a smaller breast cancer relative to your breast size, then a simple removal with a lumpectomy is very, very reasonable and a wonderful treatment option. If you have tumors that are in multiple different parts of your breast, so that's called multicentric disease, then you may be better treated with a mastectomy in that setting versus multiple individual removals. If your tumor is large relative to your breast size and we can't adequately remove it, then we might recommend a mastectomy. If you have multiple personal risk factors or genetic testing that's suggestive that you may have higher risk for another breast cancer, we may consider a mastectomy in those settings if you've had radiation before. So it's a highly customized conversation, but most of the time, a mastectomy is not the default treatment anymore. We try to see if there's a way to preserve the breast, and then it becomes hopefully choice, especially if that breast cancer is caught early enough that you can choose which treatment makes sense for you.
Okay, thank you. I think this next question will give all three of you an opportunity to respond. It's about managing side effects. What strategies can patients use to manage side effects, whether they're from surgery, radiation, or medical treatments? Who wants to start?
Going in order, or
Whatever order you want.
All right. So we try to minimize complications as kind of the prevention. So we want to avoid side effects at all costs. Sometimes women can have chronic pain as side effects. Sometimes women can have kind of an adverse cosmetic outcome, meaning the cosmesis is not the best, which can impact mental health. Women can have swelling of the arm when lymph nodes are removed, or nerve injuries causing pain. So it's kind of complex into how we manage those potential unlikely but possible complications. Really, prevention is the key in those settings. I don't know, it would take me a while to probably go through each of those, but we kind of customize exactly what is needed for each of those, but we really try to minimize complications from happening after surgery.
Okay. And what about radiation?
so with radiation therapy, I think many times people confuse radiation therapy with chemotherapy. Radiation is localized treatment. It does not travel through the body. It does not cause hair loss or nausea. When we're treating women for a small, non-aggressive type of breast cancer, we, as I mentioned earlier, can very often do what's called partial breast radiation, which is just 5 treatments focused on the surgical area, the lumpectomy bed, as we call it. Most women who undergo that treatment really don't have side effects. Some of them will develop a week or 2 after this treatment is completed. It's given daily and takes about 3 or 4 minutes each day. 2 or 3 weeks later, they may develop some mild fatigue or mild skin pinkening or darkening, no peeling, no blistering or anything like that, but just over a local area that goes away. With whole breast radiation therapy, more women experience some mild to moderate fatigue. This treatment is given daily, Monday through Friday, over 3 to 4 weeks generally. And again, takes only a few minutes every day. On the treatment table, maybe 10 to 15 minutes. And these patients develop some mild to moderate fatigue over the course of the weeks of treatment for a few weeks afterwards, but they're still working, exercising, doing all their regular activities. They also develop some temporary skin changes, which look like a mild suntan or some, again, typically no blistering or peeling. We usually have them use a topical over-the-counter ointment like CeraVe or Aquaphor to help with any dry skin. Patients who have more advanced breast cancer and we're treating their lymph nodes, they develop these changes over a broader area on their chest wall. If they've had a mastectomy with an implant reconstruction, a lot of times they're experiencing some tightness, and physical therapy can be helpful there as well. And then probably the patients who have the most reaction are patients who have very advanced inflammatory breast cancer where there's skin involvement, where we are purposely trying to get high doses of radiation to the skin. With these patients, we tell them, your skin is going to look like a bad sunburn at the end of this treatment, but it heals in a few weeks, and we help them through that as well. There are different salves and medications that we use. Those patients sometimes will need Tylenol or even some pain medicine for the very end part of the treatment, but our other patients very rarely need any kind of.
Okay, and what about chemotherapy?
So in breast medical oncology, our most common treatments for the vast majority of patients will be an anti-estrogen medication. The most common side effects from those are not entirely unexpected low estrogen side effects. So those can be things like vaginal dryness and thinning of the tissue in the vaginal and pelvic area. Some women will have an increased risk of urinary tract infections. Some women will report hot flashes or joint stiffness. And some women, less commonly, will even have hair thinning. And so on our most common treatment, which is an anti-estrogen pill, what we are targeting is we're trying to starve the cancer cells that utilize estrogen to grow. We're trying to starve them of some of that estrogen. It doesn't entirely deplete women of estrogen, and we have different ways of managing it that are more or less impactful to a woman's production of estrogen, depending on whether she's still making estrogen from her ovaries and premenopausal or whether she's postmenopausal. And also the types of anti-estrogen medications that we utilize can be more or less strong depending on what our goals are and how much anti-cancer cell activity we need to protect the body from spread of an invasive breast cancer. So that's sort of one class of things. Chemotherapy is something that, even though we do still utilize it in medical oncology and breast cancer, we actually, in the vast majority of patients, do not need to utilize chemotherapy any longer, particularly those with a hormonally fueled breast cancer. There are some women, it's less than a third, where we would utilize chemotherapy in them. For them, we are able to actually minimize chemotherapy these days to be much less than what was used in the past. We're able to better individualize dosing, and then our supportive medications are much better. The vast majority of our patients now on chemotherapy may have some queasiness or mild nausea, but we have really good nausea and vomiting medicines where the vast majority of patients will no longer feel sick. They may feel achy from some of the immune boosters that we use, and so we use some anti-inflammatories like ibuprofen and Tylenol to help with that. We can minimize and prevent hair loss with most of our chemotherapy regimens now with cold caps, and we can prevent or minimize neuropathy or tingling of the fingers and toes with using cold packs on the hands and feet with certain types of chemotherapy. We don't use nearly as much of the type of chemotherapies that can permanently cause long-term risks to someone's heart or to their bone marrow. We do utilize those in certain situations, but the vast majority of the time we don't. In the triple-negative breast cancer patients who are being treated to cure their triple-negative breast cancer, they also receive immunotherapy. And that's something that on our end, we watch a lot of lab values and make sure that parts of the body don't get inflamed. But the purpose of that treatment is to really ramp up the immune system to help us fight the cancer. And so that's mostly a monitoring issue for us. And then with HER2 targeted therapies, one of the ways that we minimize side effects is that we utilize a more modern type of heart imaging where we do heart ultrasounds or echoes using strain technology. So we can better predict who might be at risk for changes in heart function so that we can identify and help manage them with our cardio-oncology colleagues and help prevent some of those late effects. So compared to even just 20 years ago, our treatments are less toxic, more easily managed, and highly individualized. In breast cancer as well, right now, we are testing new treatments that might replace our most commonly used anti-hormone treatments, potentially with pills that actually don't even lower the body's estrogen. And that's something that's currently in clinical trials at our institution for our high-risk hormone-positive breast cancer patients.
Okay, thank you. Just a few reminders to please put your questions in the Q&A and not the chat, because we can see them and manage them much more easily in the Q&A. And you can put your questions in the Q&A at any time. And also, please try not to ask questions that are, or comment on issues that are too personal, very personal to you, because this is being recorded. Next question. I heard that mammograms can actually cause a small tumor to spread and that thermography may be safer. Does someone want to comment on that?
I can address that. So there's no evidence that I'm aware of that mammograms increase the risk of spread of early stage breast cancers or later stage breast cancers. Thermography is an interesting technology that's now being utilized. It's using essentially infrared cameras to detect kind of hot spots in the breast. It's not a standard treatment for screening. Thermography can miss early stage breast cancer, so it's actually not great at small cancers. And the problem with thermography is if it picks up a hot spot, we can't really follow it up with thermography. You have to get your mammogram, and then we got to work it up that way. So there's not a huge benefit at this point to doing thermography. I think it's thoughtful that the community is trying to figure out different ways that we can screen women's breasts, but mammograms are the mainstay of treatment. And so I'm not aware of mammograms increasing the rate of spread of breast cancers.
I'll add to that, actually. What Dr. Turza said is excellent, and I agree. And there's no basis. So, when we do studies about how do you determine if something is, related or causative, there's no method by which a mammogram would contribute to growth or spread of the breast cancer. And I actually, in the last month, have seen 2 patients who relied on thermography to tell them that their breast tissue was normal and didn't have any concerns, and then were found to have quite advanced breast cancers with a normal thermography exam. So I agree with Dr. Turza, and I'll take it a step further, given that I have people in my clinic now that may not survive their breast cancer, that we don't recommend thermography, and mammograms not only highly recommended, but it does not contribute to spread.
This person says, I've had a mastectomy and eventually chose implants. Is there a life to implants? Do they only last so many years and then I'll have to replace them?
That's a great question. So there is no, I would say, definitive lifespan to an implant where you have to replace it. Generally, I would say implants last about 20 years. We generally won't actually replace them routinely unless there are issues going on. If you're having routine kind of follow up with your plastic surgeon, they can advise you on that a little bit further. But generally, if there's not an ongoing issue with your implant, I would leave it alone. I've seen women's implants that are 50 years old without any problems. So just because it's been in there for a long time doesn't mean it's actually dangerous. As long as your implant doesn't have any evidence of rupture, if your implant has ruptured, I definitely recommend getting that evaluated and exchanged. You don't want to leave, especially if it's a silicone rupture, you don't want to leave that ruptured silicone in your body. You want that removed and replaced. So that's a customized question. Now, the FDA does have recommendations that are out there to say an implant will last maybe on average 10 years, although I'd say that life expectancy is rather low. It's not like there's an expiration date on that implant. They advise in the FDA to start getting surveillance with MRI of a silicone implant after 5 years of treatment and getting that every few years. The problem is that that MRI is generally not covered by insurance. So you may be paying thousands of dollars for implant surveillance that many times can be done on an exam. We can also pick up implant ruptures on ultrasound as well. So it's a great question. I think if you're not having problems, I'd probably leave your implant alone. If you're having concerns with your implant, you should see your breast surgeon or plastic surgeon.
Is the incidence of breast cancer increasing? And if yes, why?
Yes, it's increasing. I think we don't understand all the mechanisms of what's contributing to risk. We're seeing higher rates in younger women as well. I'm sure that our environment is playing a huge role. And when I say environment, this is our food, highly processed foods are potentially contributing to risk. The environment of all kind of chemicals, perhaps microplastics. It's really unknown all the different risk factors that are out there. We know obesity increases risk of a breast cancer, and we know obesity rates are rising as well. So I don't know that there's a pinpoint answer to say exactly what is happening, but we're seeing large increases. I wouldn't be surprised at some point if the screening age of mammograms drops below 40.
This woman says, "Hi, Dr. Turza. You are my surgeon at Walter Reed, and Dr. Harnden is my oncologist. I'm 5 years out this month. Is there research on why some women's cancer comes back and why some women survive and others don't?"
I cannot answer this. So what's interesting is that in the past, we would use the information that we gathered from surgery, the size of the tumor, the lymph node status, and the receptors. We would utilize that in both risk of early recurrence and risk of late recurrence. And as it turns out, that leap is not entirely precise, and we can do better. And so what we're doing now is we have some new tests that we can send at the 5-year mark in women with estrogen positive breast cancer that's either HER2 positive or HER2 negative. And there are some novel tests that can help us determine in the post 5-year time period looking forward, is there a high or low risk of recurrence for an individual, what that risk precisely might be, and then are there any levers that we can pull, for example, utilizing a longer time on anti-estrogen medications to decrease that risk. And so we have some new tests that we can send in that setting for women who are ER positive, HER2 positive, or ER positive, HER2 negative. In the other settings, ER negative, HER2 positive, or triple negative, those women actually by the 5-year mark would only very rarely recur after that. So if you have a breast cancer that was fast growing and needed aggressive treatment and was either triple negative or ER negative, HER2 positive, then by the 5-year mark, I give you all the high fives and I pull out my pom-poms and tell you that it is very likely you will never have a recurrence. And then in the ER positive setting, that's either HER2 positive or HER2 negative, we now have new testing we can send to help us determine what is that late risk, what can we do about it, and what should we do about it. Now, if we look forward in the future, I actually think the direction that we're headed is looking at cell-free DNA, circulating tumor cell DNA, the platforms that are currently available that work in other cancer types are not yet working in breast cancer very accurately. And so there are some that you may hear about on the market. Those are not yet having good sensitivity. They're not telling us that someone might recur, and they don't have good specificity. Sometimes they say someone will or won't recur, and that is inaccurate. And so we do have some platforms that are currently being tested that I think in the next 5 years will play a really important role in late recurrence risk and what we might do about it. But we need a few more pieces to the puzzle.
Okay. Here's a very quick question going back to implants. How would I know if my implant ruptured?
If you have a saline implant, it's generally pretty obvious. You'll get your breast reconstruction will essentially very much change in its appearance. For a silicone rupture, it can be a little bit more challenging because if the capsule that your body forms around it is intact, it may actually retain the shape. Some women feel kind of a pop or a change that's happened when that occurs. Sometimes it's a traumatic event that's triggered it. Sometimes it feels like something is different. If you feel like something's different about your implant, you should definitely get evaluated. And in many times in that setting, we will get the imaging just to confirm, because I can't say that with 100% certainty on a breast exam that an implant rupture has happened. So it's kind of, it can be harder to tell. But if you're noticing any subtle changes, or your provider kind of notices all of a sudden there's a new change in the appearance of your reconstructed breast, sometimes that can be a sign.
Okay. Can you please discuss any breakthroughs in treatment of breast cancer over the past few years, and what can we expect in terms of new promising treatments that may be available soon? I imagine this might be a question for all three of you.
I think that Dr. Harnden just discussed really kind of summarized a lot of that.
Yes, I mean, I would say that in I think breakthroughs that have been recent in curative breast cancer are using immunotherapy for triple negative has improved cure rates and survival by about 10%. And as we follow those women for longer, probably by more than that. In the estrogen positive, HER2 negative setting, our potential biggest breakthrough in the near term, next few years, is probably, hopefully, revolutionizing anti-hormone therapy and how we might make that more targeted than just lowering estrogen. In the HER2 positive setting, our biggest breakthroughs are antibody drug conjugates. And the way to think about those is those are weaponized antibodies. So we can create antibodies against certain receptors on the outside of the cancer cell, and then we can attach kind of like shopping bags to the arms of the antibody that contain in it payloads, is what we call them. And it's kind of like a Trojan horse. It can approach a cancer cell, enter through a doorway or a receptor, and then drop a bomb of sorts, like a Trojan horse dropping the soldiers inside of the castle walls. That's how our antibody drug conjugates work. And that is sort of the mainstay of how we are improving cure rates and improving survival in both the curative and metastatic setting. There are now women in the curative setting that we are curing that in years past that would have been very difficult or unlikely. And in the metastatic setting, there are women whose scans are completely clearing with some of these very new and novel treatments. And essentially what it allows us to do is take a treatment that would be too toxic to put into the bloodstream, and you attach it to something that can get inside of the cancer cell specifically, and then it can drop something inside of the cancer cell that we otherwise it would not have been safe to give someone. And so lots of interesting area of breakthroughs. And then, as I mentioned, being able to identify down to a single cellular level if someone has any cancer cells left in the body is an area of ongoing current research. And then both Dr. Turza and Dr. Hetelekidis have major advances in their fields as well.
I'd say in general for surgery, what's happening is we're de-escalating care because the other treatments are becoming so effective. So essentially what I mean for that, and I think the exciting area of change that's happening on the breast surgery front, is we're decreasing the amount of especially axillary surgery, so lymph node surgery. We used to need to remove all of the lymph nodes or the majority in the lower part of the armpit as part of cancer treatment. As something called sentinel lymph node biopsy emerged, removal of just the first draining lymph nodes that replaced the standard of removal of larger volumes of lymph nodes. And now what's happening is we're highly customizing even if we need to do lymph node biopsies. So the SOUND trial is a big trial that came out recently that's very exciting. So that was a 2023 trial suggesting that even in women who are even a little bit younger, maybe we don't for really kind of small tumors, favorable risk factors with them, maybe we don't actually need to do axillary surgery as part of their staging because it's not having significant impact on their overall care and survival. So I'd say we're highly customizing axillary surgery for women now who have known axillary disease, so small disease burden in the axilla and are getting chemotherapy. Many times we're actually able to avoid now axillary dissections if they have complete responses of their tumor, that it's gone away after chemotherapy. We can avoid extensive removal of the lymph nodes in that setting. So in general, I'd say the bigger breakthroughs that are happening with surgery is we're de-escalating kind of the amount of extensive surgery that we used to do.
And in radiation oncology, we also have been de-escalating. I mean, treatments that used to take 5 and 6 weeks 15, 20 years ago now take 3 weeks. And there are situations that we can do treatment in just five sessions. Importantly, people have been afraid of radiation therapy to the left side because of potential effects on the heart. This is something that used to happen in the 70s and 80s. Doctors didn't appreciate that you shouldn't give too much radiation or any radiation to the heart. You should try to avoid it, but they saw about 10% of patients getting developing heart problems subsequent to left-sided radiation. Throughout the 80s and 90s, the techniques changed, so they were a little bit more careful, but it really wasn't until we had CT scans so that when the radiation therapy, which is custom planned for each patient, could be planned in a way to avoid the heart. For the last decade or more, the technique that's been used when we treat on the left side is to treat the patient only when she's holding her breath. This is very easily done, and what happens is the heart moves back and towards the feet, away from the breast. And so modern series are showing that there's no risk to the heart with these kind of techniques. But if we have a patient who is unable to do that, sometimes we will put them on their stomach and let the breast hang down. Or we are very fortunate at Inova, we're one of about 45 centers in the country. We have proton therapy where we can make the radiation go a certain distance and stop right in front of the heart. Another thing that has been really great and being looked at, the research for this has been ongoing. It's still not ready for prime time, but I'm hoping very soon, is a test that will tell us in which patients we can avoid radiation altogether. We know that if you take a patient population that has early breast cancer, stage 1 breast cancer, and you just do a lumpectomy, in general, the risk of recurrence can be 30 to 40%, but that means in the rest of the patients, 60 to 70%, they're not going to have a recurrence. Currently, we give radiation to all of those patients, but hopefully soon we'll have a prognostic tool to tell us which patients are in that 30 to 40% group who can benefit from these various ways to administer radiation.
Okay, thank you. Here's a thoughtful question. What question should I ask when it comes of my physician when it comes to understanding my prognosis, life expectancy, how to plan for palliative care, hospice care? What should that discussion be like?
The
May I take that,
question,
Dr. Harnden? Yeah.
yes, so the question sounds like maybe you're alluding to someone who has a spread breast cancer. So I would say that I'll sort of give you both answers. In the curative setting, I view our role in medical oncology as being the person who explains in several different ways what the chances are of your cancer spreading if you do this versus this versus this. And I view our role as defining what those numbers look like in not just a statistical setting, but also explaining it where people feel that they understand the cure rate, the risk, and then in a very logical, mathematical way, what is the benefit of each thing I choose? And what does that leave me with at the end of this in terms of my risk in the future versus my cure rate? In the spread breast cancer setting, that is a really important and really complicated question. I tell my patients with a spread breast cancer that I try very hard to make sure that I'm giving them and myself and their family all the signs that we can utilize in figuring out how long do we think this treatment will work for? What do we think that means in the short and long run? And what kind of advanced care planning should we be discussing at various time points? At the same time, it's really difficult because you're never correct in whatever you estimate. And that means that you are unintentionally misleading everyone in what their prognosis is. I have women that I did a treatment with them that we both would have labeled a Hail Mary pass. And 10 years later, they've followed me from Duke to here and continue to come. And I was the person who told them a very long time ago that this would not be what we were doing a decade later. And so therefore, I think that I always discuss things as a range of what that prognosis might look like. My patients in your situation can do as well as X. In certain situations, if things don't go as well as we want, then it can be like this. And I explain that. And then I usually signpost for them of what data do I use to help me stratify which of those scenarios they're closer to. And then what is that sort of right in the middle? And then one of the biggest challenges for all of us is that each treatment someone is on in the metastatic setting, my hope for them is that the treatment they get after that actually isn't currently on the market. And one of my goals for my metastatic patients is to always tail them behind science, where I have a new treatment for them by the time they need it. And if we sort of maintain that pace, which I do with, I would say, the majority of our metastatic patients these days, then whatever I told them at the beginning as the average is just fully a lie by the time we get to the third line of treatment. And that is always the goal.
Okay, thank you. Well, we are just about out of time. We had some amazing questions and responses this evening. I want to thank our panel. We really learned a lot.